How is the workload, sir? Is getting busier?
Yeah, bit busy now.
We're good to go, sir.
Kaladhar, over to you.
Yeah, sir. Good evening, everyone. Welcome to our Tuesday masterclass webinar from the Department of Critical Care Medicine, Yashoda Hospitals. We are conducting these sessions very regularly, without failing, every Tuesday. So almost 3.5 years. So these are the masterclass is basically designed where the students present, the examiners, 2 students present, 2 examiners will be there. These sessions are most sought after and very helpful to the students as such, and many feedbacks during exams, they helped a lot. That's what we got. And for today's webinar, the topic for discussion is acute liver failure. So for this, I welcome Dr. Sunil Karanath sir. Sir is the chairman, head of the department at Manipal Hospitals, Bangalore. Very well known. Sir's lectures are always very interactive and very eager to listen to him always. And welcome you on board, sir. And Dr. Anant Vikram is the Senior Consultant Critical Care Medicine from Medanta Hospital, Gurugram. Welcome you, Dr. Anant. And to present today's topic, we have 2 students, Dr. Arun Kumar and Dr. Jyotsna. Both are DrNB final year students. They are from Virinchi Hospitals, Bangalore, Hyderabad. So over to you, Arun. You can start the session. And we have with Dr. Venkat Raman Kola sir also. So sir is...
Over to you, both of our teachers, and thank you for your valuable time. It is a privilege and honor to host you both, sir. Over to you, both of you, sir.
Venkat.
Can I start, sir? Yes.
Yeah.
Good evening. Good evening, sir.
Go on. Yeah.
So a 19-year-old female presented to her ER with the complaints of fever for 4 days, arthralgia and myalgia for 4 days, generalized weakness for 4 days, vomitings 3 episodes 1 day, and vague abdominal pain for 1 day. So presenting illness. So she's a 19-year-old college-going student, presented with the history of fever for 4 days, which was acute onset, high grade in intensity, intermittent in nature, not associated with any chills or rashes. The patient had arthralgia and myalgia for 4 days along with fever. She also had history of generalized weakness and poor food intake during the course of the febrile illness. She was taking self-prescribing tablet dolu 650 twice a day for fever. Patient was taken to a nearby hospital on day 4. There is no history of any Ayurvedic or herbal medications, where her CBC was evaluated and found to have thrombocytopenia, the platelet of 83,000, hemoglobin 13.8, and a count of 6,000. LFT is crossed within normal limits. Dengue NS1 was done on day 5 of illness and turned out to be positive, for which she was referred to a higher center and patient came to our service on day 5 of illness. Past history, no history of similar complaints in the past and no known comorbidities. Personal family history, normal bowel and bladder habits, so normal sleep pattern, mixed diet, and no significant family history was noted. General examination. So patient is awake, obeying commands, Jesus E4, B5, M6, moderately built and nourished with a weight of 48 kilograms. So no pallor, icterus, cyanosis, clubbing, lymphadenopathy, edema seen. Generalized macular erythemus rash was noted and blanching was present. So pulse rate of 93 per minute, BP was 100 over 64 millimeters of mercury in supine position. She was saturating 95% on room air. She was febrile, temperature noted was 100.2 Fahrenheit, and sugars were 100 milligrams per deciliter. Systemic examination. Higher mental functions were intact, moving all 4 limbs, power by 5/5 on all 4 limbs, no deficits. Cardiovascular system within normal limits. Respiratory system, vesicular breath sounds were heard, and decreased breath sounds were seen over the parietal basal regions. Her abdomen soft, no distension. Ognomegaly and no tenderness was not noted. Bowel sounds were normal. Point of care ultrasound, parietal pleural effusion, minimal effusion was noted, and ascites was not seen. Can you proceed, sir?
Based on your history and examination, apart from the dengue, which is NS1 positive, what other differential would have you kept for such a history and examination?
The patient came to
was not there.
So the patient came to us initially with the history of fever for 4 day history of fever and 1 day history of pain abdomen and vomiting. 19-year-old female. So I would think of any acute cholecystitis or any acute pancreatitis. So if there are any history of outside food intake, I would think of any viral hepatitis also, or any viral fever. Young females, sir, UTI is also a possibility. Presented with vomiting, so pyelonephritis is also a possibility. So I would like to think in these lines, sir. And had the patient had history of any diabetic in the past, DK also can present with pain abdomen with any underlying
Any other possibilities you would consider in this time of the year?
Tropical illness also will consider.
Such as?
Malaria, leptospirosis, and scrub. These things, dengue. These things we will consider at this point of time.
Chikungunya?
Yes.
Yes, sir.
Patient arthralgia as well.
Yes, sir.
Though you could argue that arthralgia can be a little bit later onset in chikungunya. It may not happen with the fever, but that is a possibility as well. Okay, good. Okay.
Shall we proceed, sir?
Yeah, please proceed.
Yes, please proceed.
So after the examination, patient had was admitted. So since the patient had come to us with the positive dengue and with history of fever, positive dengue and pain abdomen and vomiting, so we classified the patient as dengue with warning signs. And since the patient is on day 5 of illness, so for close observation monitoring, patient was shifted to our intensive care unit. So on the blood picture on arrival to our ICU, the patient hematocrit was 40.6. This is the baseline hematocrit we have with a hemoglobin of 14.3. So outside hemoglobin we saw was 13.8. There is a leukopenia 2,500 counts was there. It was 50,000. So SGOT was mildly elevated 102. SGPT was 46, and the coagulation profile was within normal limits. So they repeated the dengue panel. So dengue IgM was 12.8 and IgG was 54.9. Dengue NS1 antigen was again positive. So with this, we interpret the patient probably to have secondary dengue because IgM-IgG ratio was more than 1.2. So possibly the patient would have had an unnoticed dengue in the past. So we label the patient has secondary dengue in our case. So we diagnosed as secondary dengue with warning signs, and patient was started with IV fluids. 5 ml fluid bolus was given, followed by 100 ml per hour. And based on ultrasound guided, we were giving fluids, and antiemetics and antipyretic symptomatic management was being done, and vitals output and hematocrit were monitored.
How do you generally classify dengue?
Dengue, sir, as per the Indian guidelines, we have mild, moderate, and severe dengue. So dengue without warning signs can be classified as mild dengue. With warning signs is moderate dengue, and severe dengue is dengue with a plasma leak or any bleeding, shock, classified as severe dengue. And again, subclassified as A1, A2, B1, B1, C2 based on the presence of any comorbidities or not. 1 is without comorbidities and 2 is with comorbidities.
So when do you expect NS1 to rise in a patient with dengue?
NS1 can rise within 24 hours of illness, and day 1 of illness, NS1 can rise.
Will be seen till day 5.
Day 5, yes.
Day 5 to day 6.
And IgM, dengue IgM?
Usually rises around day 4 to day 5.
Yes, generally peak around day 6. And
can persist up to 60 days also.
IgG.
Can persist up to 60 days also.
If a patient comes to you with dengue or dengue warning signs, what are the things that you would do in terms of the initial, not this patient, let us say somebody is coming with dengue and warning signs. What are the monitoring variables that you will be looking for over the first 48, 72 hours?
Hematocrit we have to check, sir. Because any raise in hematocrit more than 10% is about 10% the baseline value is indicates that there is increase in severity.
active plasma leakage.
Active plasma
Every
leakage.
6 hours we monitor the hematocrit, and patient urine output has been monitored, and along with the serial hematocrit evaluation.
Anything else?
Pulse pressure. The patient is
Blood pressures, pulse pressure, CRT, we have to be keep on checking. Because there is a chance, dengue with warning signs, there's a chance to proceed to severe dengue, that is a shock can happen. So we have to monitor these things.
How do you base your fluid therapy for these patients with dengue?
Initially we start with 5 to 7 ml per kg of fluids we can give, sir, and further.
All patients?
Sorry, sir.
All patients? Everybody you start with 5 to 7? If you
No,
met
sir.
up 55?
If the patient, depending upon the volume status of the patient and depending upon the comorbidities, sir. So usually this is an arbitrary values 5 to 7 ml per kg. So based on the ultrasound and the patient's hemodynamic parameters, we tailor to each patient, sir. We have to look for the building up of the ascites and the plasma leakage. We look by ascites and the pleural effusion, and depending upon the progression of effusion, we can titrate fluid accordingly. And with the hematocrit, if we give serial hematocrit we are monitoring, if we give a fluid and ongoing maintenance, suppose 100 ml per hour we are giving, and 6 hourly hematocrit is rising, which means there's an active plasma leak. And if there is aprofiling on the lung, and if there is no rising ascites or effusion, we can give some fluid boluses and we can reassess. So based on that, we can, with regular assessing and bedside focus, we can tailor our therapy. So there is.
So 100 ml, if it is a 30 kg 100 ml, or if it's an 80 kg 100 ml?
So depending upon the patient's response and the fluid status, we need to monitor. So the patient is having, young patient with no comorbidity as in our patient. So we can increase to further more also, and we can safely give some more fluid also. Suppose the patient is having, some cardiac issue or where we can't give more fluid, even the patient is, so accordingly we'll tailor the fluid depending upon the response.
Let us take this. See, it is very rare to get this kind of immune reaction or immune phase in people who are elderly and all that, isn't it? We often see this problem, the leaky capillary phase and other things is more often seen in the younger people. So let us say in this patient, what is their criteria? Always when we talk about fluid, these days we talk it in terms of per kg body weight, isn't it? We don't talk in terms of 100 ml, 200 ml, 500 ml, doesn't mean anything. So in that context, is there a way you can tell me how do you guide our fluid therapy?
So initially,
I agree with you. I think you're monitoring ultrasound, CRT, lactate. Actually, lactate was something I wanted you to tell. Anyway, that's also something we do use as a marker for our monitoring, okay, especially in ICU. So one more thing, just, I mean, if I may take on off track, is that always remember the assumption is that when a case has been given to you, you are in the world's best hospital. So use whatever you have at your disposal in terms of, I mean, of course, what you do, don't say I will put PA catheter and all, but whatever you have at your disposal, what is there in the world's best facility, you can always say. So along with your ultrasound, focus, VTI, of course, you CRT, also say lactate monitoring also is something you do as a marker, okay? Right, that apart, in terms of kg body weight, is there any difference? Or you said 100 ml, it's a bit vague for me.
So 5 to 7, if the patient is not in shock, 5 to 7 ml per kg of crystalloids for 1 to 2 hours, and followed by 3 to 5 ml per 5 to 7 ml per kg for next 1 to 2 hours, and then 3 to 5 ml per kg, and we can contribute as maintenance.
Right. So if there is, where will you give more fluid? In what context will you give more fluid to these patients?
The context of rising hematocrit.
Okay.
Rising lactates as well.
Okay, maybe may
I
not be.
think
Rising hematocrit, definitely. So what is the fluid, how much of fluid are you going to give in terms of per kg body weight in that setting?
To start with, you can start with initial bolus of 10 up to 10 ml per kg also we can give, sir. If there is no signs of fluid overload and IV is collapsing, we can give up to 10
per kg. Yeah, 10 to 20 ml per kg you can have over a period of half an hour to 1 hour. Okay. when the patient is in shock or when the patient's hematocrit is high, above 50, because you want to get the hematocrit down to around 40 to 45. So earlier you do, better it is. All right. So then the rest of the rules hold as you said. Okay. Yeah. Right.
Coming to day 2 of illness, so patient was having persistent pain abdomen. So now she complains pain over the epigastric right and left iliac fossa regions. No signs of bleeding were noted. Heart rate, vitals, heart rate was 102 per minute, BP 100 by 60 millimeters of mercury. So saturating 96% on oxygen, 2 liters per minute. Bilateral basal regions, breath zones were decreased. And point of care ultrasound, again, bilateral pleural effusion was seen. Ascites was not noted at day 2 of admission. The labs. So there was a further decline in the WBC and the platelet count. It was 50,000 earlier. It was dropped to 30,000 now. And the bilirubin slowly started to rise. It's 1.47 today. And OT-PT, that SGOT was further worsening of OT was there. Now SGOT, AST was more than 2.5 times elevated. No. And for persistent pain abdomen, we did the lipase also, because dengue can present as acute pancreatitis also. Lipase was within range, and there is no coagulopathy noted. So we did a formal ultrasound, and there is mild ascites, and bilateral pleural effusion was reported.
The patient's platelet count is now 30,000. Would you like to transfuse him?
No, sir. The patient is clinically not bleeding, so there's no indication to transfuse.
Any patient who is not bleeding, there is no indication to transfuse a platelet. We'll move, I think.
So we did the blood gas analysis at this point of time. So the pH of 7.35. So bicarb was 18.1. That is acidotic side. So the using the Winter's formula, 1.5 into bicarb plus 8, the patient comes to 35. The patient was appropriately compensated. So the delta ratio comes to 1.6. So this is pure hagma, sir, for this patient. So we attribute the cause of hagma to the lactate is 2. So we see the fluid deficit, secondary to fluid deficit, and hypoperfusion. The patient had hagma is we diagnosed from this ABG. So we gave some more fluid boluses and was continued on IV fluids 100 ml per hour. And based on that, it kept on close monitoring, and intermittent fluid boluses has been given to the patient. So on the next day, the day 3 of illness, in the morning, the patient was more drowsy. So GCS fell to 9/15. Pupils were bilateral, reactive, 2 mm, equal sized, moving all 4 limbs, no deficits. GRB is 96 mg per deciliter. BP 100/56. CRT was 3 seconds. Pulse rate tachycardia, pulse rate 100 per minute. Respiratory 28 per minute, and she was saturating 96% on face mask 6 liters. Output was 25 ml per hour. So for suspicion of bleeding because of thrombocytopenia and the patient was drowsy, we did a CT brain showing mild cerebral edema, and however no bleeding was noted. So we did ABG at this point of time. pH was 7.32 and bicarb fell to 12.8 and lactate was 4. So there was a hagma there was metabolic acidosis, respiratory alkalosis, and it comes under hagma. So labs. So the WBC was 2,700. Platelet further fell to 8,000. There was AK at this point, so creatinine 1.58. So there is INR of 6.6 with APTT of more than 120. That bilirubin was 2.67 and SGOT was elevated to more than 10,000. But ALT was more than 2,500. So with this picture, we diagnose the patient has acute liver failure, secondary to severe dengue.
So suppose this was the state when the patient reached you, rather than the earlier state. What other history would you like to elicit in this patient, if he had come with this profile to you?
Yes, sir. So any history of any underlying for any history of medication history. to rule out any paracetamol overdose or any history of any drugs of abuse, any ecstasy, or any mushroom poisoning, because they can present this hyperacute presentations. So any to a young female patient, so any history of autoimmune disease in the past to rule out any autoimmune hepatitis. So any history of tuberculosis in the past, whether could be because of ATT-induced liver failure. So this or any other any travel history, any outside food consumption to rule out any hepatitis. This history led to
Any relevance of jaundice to encephalopathy time in the history?
Yes. We can grade the acute liver failure based on the grading into hyperacute, acute, and subacute O-grade classification we have. Within 7 days is hyperacute, the jaundice to hepatic encephalopathy time frame. With 7 to 28 days, it is subacute, and more than that is hyperacute. Sorry.
Less than 7 days is hyperacute, 7 to 28 days is acute, more than 28 days is subacute.
But see, it has a prognostic significance also. Jaundice to encephalopathy time. Your prognostic models like the King's College,
More than
paracetamol poison take into account the jaundice to encephalopathy time also. And also you need to take care of any history of transfusion. Why is it so? You received a patient from another hospital. Whether he has received transfusions or not, why is that history important?
Transfusion-related transmitted hepatitis B.
Especially the fresh frozen plasma.
For any CMV.
No, see, that is important because you need to see whether that PTINR that you have is a corrected one or uncorrected. Because again, it has a prognostic significance in a patient with ALF.
How do you define a patient with ACLF? What is ACLF?
It's acute and chronic liver failure, sir. So based on the European classification, so there are two schools of thoughts for defining ACLF. So one is the European classification. So when the patient presents to us with any acute decompensation and if there is any organ dysfunction, so both should be there. Acute decomposition in the form of hepatic encephalopathy or ascites or any GA bleed with any organ failure. Organ failure, it could be any organ failure. It could be the brain, the heart, the coagulopathy, or the cardiovascular and shock or hypertension or kidneys. So with this organ failure, this can define as ACLF. So other definition is North American definition. So here we define as with 3 parameters. In the presence of known existing chronic liver disease, the patient presenting with worsening jaundice and coagulopathy more than 1.5 INR, we can define as ACLF. And another consortium is, so the presence of more than 2 extra hepatic organ failure can define ACLF.
Do you have a severity grading for it?
Yes, sir.
Yes, sir.
Can you grade it for me? Classify as per severity.
We have
Grade 1 is single organ failure, sir. If creatinine is more than 1.5, along with cerebral involvement as well, then it comes under grade 2, and more than 2 organ failures, it comes under grade 3, sir.
Can you enumerate the etiologies for acute liver failure?
Yes, sir. So first, any viral illness can cause acute liver failure, sir. So viral illness causes will be like hepatitis A, B, D, E, and D, and dengue illness and leptospira scrub. Dengue and CMV, EBV, HIV also can cause acute liver failure. Then we have any septicemia can also lead to acute liver failure, and then
drugs and toxins.
It can cause drugs. It can be paracetamol or non-paracetamol like ATT, mainly isoniazid, and antiepileptics like valproate, phenytoin. These also can cause
sulfur drugs. Also can.
can cause. And poisoning with yellow phosphorus or mushroom poisoning or carbon tetrachloride, these can also cause acute liver failure. And
Acute Pachisia syndrome, Wilson's disease,
veno-occlusive disease, autoimmune hepatitis,
fatty liver of pregnancy,
and HELP syndrome, and any malignancies, metastatic liver disease. These can also cause acute liver failure.
Or can be due to secondary, they can be further classified as primary ALF and secondary liver failure. So those secondary to underlying disease like underlying malignancy or underlying to secondary to HLH or any infiltrative disorders or secondary to like tropical fevers, these will come under secondary acute liver failure. Other etiologies come under primary.
Which is the generally most common etiology in the Indian subcontinent, and does it differ from the Western data?
In India, viral hepatitis is more common.
Yeah.
Followed by that, drug-induced, mostly due to ATT. It is more second most common is ATT-induced hepatitis. In other parts of the world, paracetamol-induced acute liver failure is more common.
Yeah.
Keep going. I think we proceed with the presentation.
Then following the investigations, the electrolytes are within normal limits. Phosphorus were 9.3. Serum ammonia was 120. So 2D echo, there was global LV hypokinesia, and LV systolic function was monitored LV dysfunction was seen. EF was around 48%. So the diagnosis we made as liver failure secondary to severe dengue. So issues currently are coagulopathy, encephalopathy, worsening LFTs, rising trend of lactate, AKA, and myocarditis.
Can you go back to the previous slide? One more. So, is there any prognostic significance of serum phosphorus in acute liver failure?
High phosphorus levels, they indicate that there is a worsening of the liver functions.
They have a poor outcome.
Poor outcome.
So, yeah. Or if the levels are decreasing, so that the liver is regenerating and there is more ATP formation, that can be also look at. And is there a correlation or any prognostic significance of serum ammonia?
In acute liver failure, elevated ammonia levels usually hints towards hepatic encephalopathy, and persistent elevation of ammonia carries an unfavorable prognosis.
There are more chances of complications and mortality if the patient has a persistent ammonia levels. We can move forward.
Day 3 of admission. So the same day, sir, the patient was intubated for airway protection. So around afternoon, the patient had one episode of melena. The patient was started on Visnac infusion. After loading dose of 150 mg per kg or 300 mg per hour was started. So there was the patient had one episode of melena. The platelet was less than 10,000. So 1 unit of SGTP was transfused. In view of liver failure, and one session of high volume plasma exchange was done. Description of plex. So the total blood volume was the patient weight is 48 kilograms. For easy calculation, make to plus 50. 50 into 65 into 1 minus hematocrit. Hematocrit is 40. So it came to 1950 ml of plasma volume. So normally for 1 to 1.5 times the plasma volume exchange, normally it has been done. So for here we took into 2.5 times, it came to 4.8 liters. So the replacement, we took 20 FFPs, so 20 into 200. With 4 into albumin, each carries 250 ml. So 4 into 250 comes to 5,000 ml. We replaced, was done over 4 hours.
Can you enumerate the types and techniques of plasmapheresis?
There are 2 types of centrifugal or membrane-based techniques we have.
So that would be the techniques. And what are the types of plasmapheresis? Like you have said, high volume plasma exchange. So are there any other types?
Standard volume,
and low volume.
We have.
So
Standard volume is 1 to 1.
High volume, low volume, and standard volume plasma exchange.
standard volume is around 1 to 1.5 liters of total plasma volume, and high volume is around 8 to 12 liters of replacement exchange we do, and low volume is less than 1. We usually around 0.5 to 0.75 of total plasma volume we plasma exchange we do.
See, the high volume is around 4 times the plasma volume, and standard is around 1 to 2, and low volume is around 0.5 of the plasma volume. And the two techniques that you said, the centrifugation and the membrane, which one is better?
Extraction ratio is more for centrifugal, but we use a membrane-based technique bedside because in view of hemodynamics.
Usually,
Current evidence says that the centrifugal may be better compared to plasma because hemodynamics may be better because you run it at a lower blood flows, and also the immunological activation may be less in the centrifugal technique compared to the membrane. What are the complications that you'll see with plasma exchange or plasmapheresis?
because of large fluid shift, there can be hemodynamic disturbances and arrhythmias during the procedure. And because we are giving the products, risk of Trali and Taco is there. And again, transfusion-related complications are there.
What else?
And see, depending upon the anticoagulation, so secondary to cited anticoagulation, most commonly hypocalcemia and metabolic alkalosis is common after flex and close monitoring of calcium and TB. If you mostly centrifugal, we use cited as anticoagulant, and membrane-based we use heparin-based anticoagulant. And if centrifugal, commonly hypocalcemia and alkalosis is seen.
How does dengue affect the liver? What is the pathophysiological mechanisms described?
Dengue has a cytopathic effect on the liver cell. So dengue, there is neutralizing and non-neutralizing antibodies. So we have the E protein and the M protein. They are neutralizing antibodies. They usually, what we have, the third one is the NS1. That's a non-neutralizing antibody that will be circulating in the blood. So that has two actions. That has a effect on the vasculopathy and cytopathy that is caused by the circulating NS1 and the immune complex that forms the this vasculopathy and cytopathy. So in the liver, it affects the Kupffer cells and it damages the liver function synthesis. It causes a state of relative hypoxia to the liver.
So among the two effects that you said, cytopathic and the immune, is there any time difference of what occurs first and later?
The cytopathic effects precedes the vasculopathic effects in dengue.
Yeah. Okay, we'll move on to the next slide.
So serial focus has been done because the patient, we have the patient with hepatic encephalopathy and with elevated ammonia levels. So ONST was 5.5 both sides. Lung ultrasound again showing bilateral fluid effusion and ascites was seen. However, no further episodes of melena was noted. So the plex got completed by around late evening. So the night we repeated one more coagulation profile to look for any bleeding or worsening of INR to if the patient needs any more further replacement of blood products. So INR has come down to 4.4, calcium was 9.5, and there was improvement in the platelet count from 8,000, it has come up to 14,400. So pH there was a slight improvement, 7.31, bicarb was 12.3. Again, this patient has hugma plus respiratory alkalosis. And the lactates again elevated 6. So probably attributed to the underlying failing liver.
Can we go back to the previous slide?
Yes, lady.
So what is the inference of a ONSD of 5.5?
So more than ONSD of more than 5 correlates with ICP of more than 20 millimeters of mercury.
Why
So
does-
5.5, that is increase in that is a cerebral edema, sir. So we keep the trend of so that if we see keep monitoring the ONSD, the trend of worsening of any edema is there or not, we can get to know.
Why does the ONSD increase?
So because the optic nerve, the sheath is closely attached to the brain. So any increase in the brain puts a pressure over the optic nerve also, and that exerts pressure to the sheath, and that's why there is the edema, and that's what the diameter of the optic nerve increases. The sheath increases.
Jyotsna, you want to take this answer?
Because of the increase in like edematous changes in the sheath itself, there will be increase in the optic nerve sheath diameter. Any increase, any further increase indicates that there will be worsening of the cerebral edema, or if there is a means there is anisocoria clinically we can see, and this ONST there is change like there is difference between the both sides, then we can also suspect because there is worsening coagulopathy and worsening platelets as well. Any bleeding would have happened, and ICH also
There is
we
a
can suspect.
continuation of your CNS, and it is surrounded by the subarachnoid space. So any increase in intracranial pressure is transmitted to the subarachnoid fluid, and that is basically what is expanding and increasing your ONST.
So embryologically, if you remember, optic nerve is a derivative extension from the forebrain. That's the reason it draws the meninges with it. That's why you are actually measuring the reflection of the ICP in the by seeing the distension of the optic nerve sheath. How do you measure the optic nerve diameter?
Linear probe we use, and over the upper eyelid we have to place it in a vertical position, and check for the behind the globe we have to 3 millimeters behind the globe we have to measure the distance, and there we have to measure the optic nerve sheath diameter, and 3 serial readings we have to take, and average of it is the we take it as a value.
Outer to outer, inner to inner. Measurement, your diameter measurement, you're going to take outer to outer or inner to inner?
Outer to outer we take it, sir.
It has to be outer to outer, because sometimes you see a hypotenuse line just outside the optic nerve. So you have to actually, because that could be the distension of the sheath, okay?
Okay.
You can have 3, and also some people do suggest that 2 transfers and 1 taken a longitudinal plane, because that will give you the measurement more, it might give you the measurement more accurately sometimes, because it depends on how you cut the optic nerve. So transfer, sometimes if it is cut at an oblique, you may get a wrong value. So you have to take 3 in which one of them may be more of a longitudinal, where you actually keep the probe more on the craniocaudal axis of the patient, so that you get the lengthwise measurement also. The same rules apply. You take it 0.3 and take a diameter, but just one more angle to take. Okay. Yeah. Any other ways of measuring ICP in these patients?
Transcranial Doppler.
Okay.
Can be.
What do you find in, what do you use in the transcranial Doppler?
We can see the MCV velocity, so MCA velocity we can see.
Okay.
And we can see the Lindegaard ratio, MCA by carotid velocity we can see. The ratio we can see, sir.
Lindegaard ratio will give you ICP? Or is there any other calculation that you would look at?
The pulsatility index we can
Yes.
Gosling's index.
Yes. Pulsatility index of more than what value correlates with the rising ICP?
1.2.
Yes, above 1.2. So above 1.2 absolute value, but more importantly, a rising trend will be very useful to say that, there is a likelihood of an ICP going up. Anything else which is now coming in as a measure of a non-invasive method, which people are using
Pupillometry.
pupillometry. Okay. Yeah.
What is the gold standard for measuring ICP?
Yeah.
Placing a
Cordmans.
So what are the risks of placing a Codman for in this patient? Would you place a Codman's?
in view of coagulopathy, we will not go for an invasive ICP monitoring.
No. So let us say you have to go for an invasive. What is the preferred method of the ICP which is done? What are the different ways of measuring ICP invasively? One is Codman's, you said. Anything else?
Intraparenchymal, subdural, extradural, or subarachnoid space we can measure.
Yeah. So which one is was being used? Maybe it's less often used these days. What was being used for ICP monitoring in these patients?
Intraparenchymal.
Is it safe, intraparenchymal?
No, sir. There's high risk of dislodgement.
So what was being used? Now dislodgement, you don't worry. Intraparenchymal, we are not worried about dislodgement. More
Risk
about
of infections and also combined meningitis and infection.
bleeding is the main thing. So subdural bolts were kind of a preferred modality in these because lesser incidence of bleeding, because you don't want to get into the parenchyma in these people. Neither an EPD nor an intraparenchymal Codman's catheter. Okay. Yeah. Okay. So how do you manage these patients who present with hepatic encephalopathy after fulminant hepatic failure with evidence of rising ICP?
Patient has to be first nursed in a 30-degree head-up position. So care to be taken to avoid fever and hyperglycemia. Achieve normal CO2 within normal range, and adequate anarcho-sedation, and hyponatremia and hyponatremia has to be avoided, and close watch of this worsening of edema. So we can take anti-edema measures with either hypertonic saline or mannitol, depending upon if there is any renal dysfunction, very better to proceed with the hypertonic saline. The target sodium is 140 to 150. If the patient is still refractory, the fulminant hepatic failure, refractory to all these measures, you can short of indomethacin 0.5 kg is also there, but there is no controls. Other than induced hypothermia and barbiturate coma has no role, a minimal role in liver failure. I'm not sure about the role of these modalities.
All right. Next slide. Move on.
The treatment given. So because the patient had fulminant hepatic failure and there's ongoing liver injury to the keeping the threshold of sepsis, we started a broad spectrum antibiotic injection, piperazine, tazobactam. The creatinine clearance was 30, so dosed it according to that 2.25 grams IV QID. Injection of vitamin K 10 mg IV OD, lactulose, udiliv, glutathione, and pantoprazole for sepsis prophylaxis. We prescribe for this patient.
What is just go back? So is antibiotic recommended? First, what is the role of vitamin K and what is the role of lactulose in a patient with fulminant hepatic failure?
Because the patient, those patients with acute liver failure, so they have more likelihood of developing sepsis because the synthetic functions of liver is lost and the immune mediator functions are also compromised. So they are more prone for developing sepsis and related and infections and related complications. So for keeping the threshold, for that reason, keeping the threshold low, we started on antibiotics in our case. Second, vitamin K for coagulopathy, we started on vitamin K.
Is there an indication for vitamin K in acute liver failure?
As per recommendations, not suggested anything regarding vitamin K.
Limited evidence for vitamin K.
Why you don't want to give vitamin K?
Because the synthetic functions of liver has already been compromised. That's been referred as elevated because of coagulopathy and so vitamin K.
Sorry, I didn't get you.
The synthetic functions, the clotting factor has been produced. The synthetic functions of the liver has been compromised, sir, in acute liver failure.
Yeah, so it should help, no, giving vitamin K. Or let us say do you want to give FFPs? You said INR was some 3, 2.5.
FFP, the patient is not being planned for any invasive procedures at the moment, and the patient is not clinically bleeding also. Only one episode of melena was there, and come to next slide, there is no drop in hemoglobin also further. So there is no indication.
Why don't these people bleed when the INR is 2.5? What is the critical care physiology in patients with liver failure? From the coagulation.
There is increase in procoagulant and anticoagulant factors as well. So procoagulant like factor 8, von Willebrand factor, these are in increased quantity. Their levels usually increase in the liver failure. And
there is increase in the circulating endogenous heparinates production is increased. And along with it, there is a release of young and more active platelets. That's why these people usually don't tend to bleed even though they have.
What is that called? What is that phenomena called? So you're right, there is increase in both procoagulant as well as anticoagulant. So what is that called? Have you heard of rebalancing? Okay. There is a rebalancing of coagulation factor. That is the new entity of how we describe these. That's why they don't bleed. In fact, if you look at these people, only 20% of them actually have hypocoagulability. They are actually more hypercoagulable in most circumstances. That's why they don't bleed, and we don't correct this unless, as you said, there is active bleeding or there is a procedure, or sometimes if people say the INR is more than 4 or 5, there could be a thing. But generally, we don't correct because INR is one thing that we use for monitoring these patients. So we don't give vitamin K, this, that, everything is not given because we want to use that as a monitoring tool. And that is one of the criteria in your decision for transplant as well, isn't it?
Yes, sir.
Yeah.
What about lactulose?
Lactulose as a modality to decrease the ammonia levels. But in acute liver failure, evidence is limited. But for any potential benefit, we have given lactulose.
Any drawback of giving lactulose in an ALF patient?
Risk of ileus and
bowel dilatation and ileus can happen with lactulose because patients, if they are going for transplant, this bowel can likely to injure during the transplantation.
And if you want to give, which is the route preferred?
or
Lactulose enema.
enema can be.
Yeah, enema is a more preferred modality because of a more local action and lesser chance of these other complications which you mentioned. Yeah.
Yes.
Move forward.
I think we are done with most of it.
So the next day, sir, day 4 of admission, day 8 of illness, the patient is on mechanical ventilator on AC mode, FA of 0.5. BP is 96/52 millimeters of mercury. The CRT was more than 3 seconds. At this point of time, the patient was started on oral infusion 0.05 max per kg per minute. Pulse rate was 110 per minute, and SpO2 was 95% on FiO2 of 0.5. Output fell down further to 15 ml per hour. In 2D echo, we could see global healthy hypokinesia with a 40% EF. Again, it has further fell. With the acid-base levels, pH was 7.29, and the patient had severe, again, pure hagma with a lactate, increasing lactate of 8.2. So, in view of, I'll complete the labs. So, the hemoglobin is 13.1, let's count 35,000. So coagulopathy has improved. Liver functions have improved. The enzymes have improved. Before Plex to more than 11,000 SGOT and more than 4.5 ALT, it has come down significantly. Electrolytes are within range. Creatinine, there was a further worsening from 1.5, it has come to 1.7. Fibrinogen is 260. So in view of severe metabolic acidosis and
which etiologies of ALF are more likely to cause renal dysfunction?
cause
Renal dysfunction.
paracetamol.
What else?
Paracetamol induced mushroom poisoning, also associated with more renal failure. And AFLP also, there is more chance of proceeding to renal failures.
Any etiology of acute liver failure presenting with hyperacute to acute phenotype in a young patient who is requiring vasopressor support, they tend to have renal involvement also. High risk factors for renal involvement in acute liver failure.
Wilson's also is another etiology which will present with increased risk of renal dysfunction. Continue.
In view of decreased urine output and severe metabolic acidosis, started on CRRT. So the prescription to started on CVV-HTF mode, dosage of 45 ml per kg per hour. The dose 17 to 45 is coming to 3 liters. So 50% of which was given as dialysate and 50% as replacement fluid. So 50% of the replacement fluid, 50%, 500 is given as pre and 500 as pre and 1.5 as post pump. So we give saline flush as
anticoagulation. No anticoagulation.
No anticoagulation.
What is the normal dose for CRRT?
So normal dose is 35 ml per kg per hour, sir. So, but concerns that the actual dose delivered is always less than the calculated dose, we chose a higher dose.
45 is too high. Generally, it is 25 to 30.
30.
Even including the downtime. 45 is high.
So if you touch 45, it comes in the range of high sort of high flow CVV-HDF, which you don't have much evidence for at this point. Even if the downtime, you are increasing the dosage is not going to compensate for that. Okay. So usually total dose, you take the renal or the AKIK study, it was all in the range of around 25 total renal dose, not even the the replacement or the dialysis part of it. Yeah. Okay.
But theoretical concern of the actual dose being delivered less than the calculated dose, which was a higher dose. Okay, sir.
What is the dose generally for CRRT if you are planning to remove ammonia?
Only to remove ammonia, hemodialysis is preferred mode, sir, because
the dose of CRRT. Dose of CRRT, what that you'll plan if you want to remove ammonia. That is as per the evidence that is available in the literature.
30 to 35 ml per kg.
Generally, it is around 40-42. So if you have answered that way, it might be the answer might have been right. But or if you're doing for a AKI indication, the dose is too high. Which is the fastest way to remove ammonia in terms of renal modalities?
CRRT is preferred.
Or
fastest.
Fastest and physical principle is asking.
Molecule.
Hemodialysis.
Diffusion, by diffusion it gets cleared. So
The small molecule hemodialysis is there.
It is a water soluble molecule, so it can be easily removed by diffusion. And since you're running your intermittent hemodialysis at a higher rate, so it is the fastest, but still CRRT is preferred. Why is it so?
the fluid shifts that happen during the intermittent hemodialysis, there will be worsening of the cerebral edema. So that's why we prefer CRRT over intermittent hemodialysis.
Next slide. Last one more slide, no?
Last.
Slide is not moving.
Not able to move the slides. Yes, sir. The patient had a worsening shock, was requiring dual supports. With the worsening acid-base levels also. So the patient died the early hours the next day due to refractory shocks. Day 5 of admission.
What are the prognostic models that are available for a patient with acute liver failure?
King's College criteria for transplant also for prognostic tool. The Clichy criteria.
Can
There
you
is
just
a dynamic.
enumerate, if you remember, what is the King's College criteria? Clichy criteria.
King's College criteria, we have paracetamol-induced ALF and one for paracetamol-induced, one for non-paracetamol-induced. For paracetamol-induced, first is acidosis, lactates more than 3 and pH less than 7.3. Along with that, serum creatinine, INR more than 6.5. Sorry, INR more than 3 and creatinine more than 3 and hepatic encephalopathy of grade 3 or 4. It is for This is for paracetamol-induced ALF and non-paracetamol-induced INR more than 6.5 or one of the 3 of the 5 things like age more than less than 10 years or more than 40 years and non-A and B hepatitis etiology and Wilson's disease and drug induced and INR less than more than 3 and bilirubin more than 17 and timeline more than 70 days. Jaundice to encephalopathy timeline more than 7 days. So
what is Alfred score?
Alfred score is it takes into parameters of INR more than 3.5, serum bilirubin, hepatic encephalopathy, and the serum ammonia of more than 120. And they have a dynamic scoring, has to be calculated on day-to-day basis, and they have a scoring system based on that.
Alfred score is more for an Indian scenario than compared to the King's College criteria, which has been validated in Western population.
Alfred score performs better than the King's College criteria also.
In the Indian
in the Indian context, yeah.
So anything else?
So just wanted to add a couple of things from the presentation aspect. So obviously this is a case which you have prepared, you presented as a slide, but this won't be the luxury you'll get in the exam. I mean, questions might remain the same, and it is not that ALF, we will stick to ALF, we may go to any other aspect, that is, as you saw, CRRT, all these discussions will come up, convection, diffusion, how do we do, which is a better modality, so on and so forth. So one of the ways, this is what I would suggest, but you can follow whatever you think, is remember that the presenting history, we try to finish your presentation in a matter of about 10 minutes, even little lesser if possible, 8-10 minutes. Give a summarized version. I mean, here it was for teaching, it's fine. But if say, for example, can you go back to the first slide? So you could say that, this is a 19-year-old girl who presented with a febrile illness or a college going student had a febrile illness of 4 days associated with, that way, make it more of a summary, because at the end of the day, what we are looking to make you consultant. So you have to have a summarized version of it. And finally, when you come to the diagnosis, what is the 2-3 punchline for why you are going to give that diagnosis? I mean, of course, here it is dengue, but you would say there's somebody with febrile illness, thrombocytopenia, rashes with a positive dengue. I would say that this is most likely dengue illness, and what kind of it? Just dengue illness, warning signs, or severe dengue, whatever it is, that way. Okay, and also when you go to the treatment part, or when the presentation part, in where you are in talking about the current admission, maybe just use a word that course in the hospital, course in the ICU, course in the ER. Those things will segregate the presentation much more, and you'll be able to put across to the examiner in a very summated way. Otherwise, we'll be actually trying to grasp information with a lot of difficulty. And for most of the examiners, this will be a case which they are also seeing for the first time. So you should make them feel that you are actually giving, or you should lead them to what you want to, rather than, beating around the bush. I mean, this presentation was good. I'm not denying that. But what I say is this luxury of time you will not have in the exam. Okay. So of this class, or out of this class, practice that kind of a presentation in your day-to-day handovers and things like that. Okay. Yeah.
Yes, sir. I think almost everything been discussed. Regarding liver support assist devices or anything, what do you think, sir, like this type of patients, is there any, like we discussed, like Mars and other hepatic support system devices, what is the role of them?
So I think, yeah, Anant, you want to take it?
So as of the current evidence, plasmapheresis has shown a mortality benefit in patients with ALF as compared to Mars. So maybe other therapies like Mars or the Prometheus does not have any mortality benefit in the current context in ALF. So a plasmapheresis would be a better choice if you want to bridge it to transplant or for the also.
ALF and even in ACLF, there is increasing data for the use of plasmapheresis per se. So I think with the advent of plasmapheresis, use of these other modalities have substantially reduced. And of course, we also have to understand the huge context of the cost which is involved in running these support devices. And there is no mortality benefit, as Dr. Anant told. So I think less and less. I mean, we have not used it for the last maybe 3-4 years. I don't know whether you have, Anant, but last more than 3-4 years we have not used
also, we have not used, I think, for last 5 years.
Yes. And there is good data both in India as well as outside India about the role of plasmapheresis itself in many of these circumstances. And I think if that doesn't happen, then he'll have to go for a super urgent transplant or something that way. Yeah.
Yes, sir. As these patients are very much prone to develop severe cerebral edema and ICP, most of the time that becomes a bit difficult, even though we follow the regular ICP controlling mechanisms. Is there any role for induction of hypothermia or barbiturate coma, maybe some brief hyperventilation? What is the stand on these 2-3 things, sir?
So see, hypothermia and barbiturate itself, I think in most contexts we have stopped using it, unless you're really desperate. But the problem is, again, that itself is will induce high risk of infection. Barbiturate, thiopentol will actually knock off the immune system so badly, including ciliary motility, the suppression of the cellular, the T cell system. It will just hammer the immunity, and these people are so immunocompromised. Unless you're really desperate, I don't think there is much role for these and if you have somebody like that, transplant is the only way forward. I would not think there is any other shortcut we can actually get to.
Yes. So I think with that I think we have come. Anything to add, Dr. Anant?
One last question. When will you not offer transplant?
So when the patient is on dual supports, or the patient is the cause of ALF is secondary to underlying malignancy, or any terms of secondary ALF, you do not offer transplant. Or the patient is having any uncontrolled systemic infection, could be secondary to ALF also, we do not offer transplant in those cases.
Or if the patient is improving.
Yeah, that is the obvious thing. So I think we discussed everything possible. Yeah. Thank you, sir. Thank you, Sunil Karanath, sir, and thank you, Dr. Anant, for coming and this platform, and I think it's very useful. These two students, I think around 100 people logged in. And thank you, Arun and Jyotsna, for bringing out that case for a very good discussion that happened. And thank you, Yashoda Hospitals and our digital and branding team for providing this consistently this platform to conduct these sessions. Thank you, sir. Good night. Thank you all.
Thank you, sir.
Good night.